Hi, my name is Grant Burke, and today I'm going to be talking about my research on the role that probiotics have in the prevention and treatment of small intestinal bacterial overgrowth. Start out, I'm just going to go through a case. Patient's name is HS. Her chief complaint is that she feels bloated. Her history and present illness. So she's a 34-year-old woman who presents to the gastroenterology office complaining of abdominal bloating and diarrhea for the past few weeks. Patient states that over the past few weeks she has been experiencing an uncomfortable feeling of fullness after eating that has continued to worsen. She notes a crampy, intermittent 4 out of 10 abdominal pain. She has been having looser stools, almost diarrhea-like, for the past few weeks as well. She reports that she's had about 3 of these episodes a day. She denies any nausea, vomiting, unintentional weight loss, hematochezia, melena, fever, or chills. Also has had no recent travel or antibiotic use. Her past medical history is significant for gastroesophageal reflux disease, for which she takes esomeprazole 40 milligrams, 1 capsule every morning. She has no known allergies. She has had tonsillectomy and wisdom teeth removal in the past, and she is up to date on her immunizations. Her social medical history. She lives at home with her husband and 2 sons. She knows she could improve with her physical activity and diet, but her life is sometimes too busy. She is currently employed as a school teacher, and she denies any tobacco use, alcohol consumption, or recreational drug use. Her family history. She has mother and father who are alive and well. Her oldest son is 10-year-old and healthy. Her youngest son is a 4-year-old and healthy. I'm going to go over an abbreviated review of systems of her history. So her general is negative, HENT is negative, cardiovascular is negative, respiratory is negative, gastrointestinal is positive for abdominal pain/cramping, positive for abdominal bloating, positive for loose stools. Negative for nausea, vomiting, hematochezia, and melena. GU is negative, neurological is negative, musculoskeletal is negative, hematologic is negative, and skin is negative. Her physical exam. Her vitals, blood pressure is 130/80, pulse is 84, temp is 98, respiratory rate is 24, her weight is 204 pounds, and her oxygen saturation is 100% en room air. General, she is a 34-year-old female in no acute distress, well-developed, well-nourished. HENT, pupils are equal, round, reactive to light and accommodation. Extraocular movements are intact, mucous membranes are moist, head is normocephalic, non-traumatic. Cardiovascular, heart rate is regular rate and rhythm. No murmurs, rubs, or gallops appreciated. Respiratory, lungs are clear to auscultation bilaterally, no wheezes, bronchi, or ralls. Abdominal, she has some mild diffuse suprapubic tenderness, normal active bowel sounds in all 4 quadrants, no rebound, guarding, or rigidity. Negative McBurney's tenderness and negative Murphy's sign, no CVA tenderness. Musculoskeletal, she has full range of motion of the bilateral upper and lower extremities. Neurological, she is alert and oriented appropriately ×3. Cranial nerves 2 through 12 are intact. Skin is warm and dry. Capillary refill is less than 2 seconds. She has no rashes or lesions. Her laboratory evaluation that was available at the time of us seeing the patient, CBC with autodifferential demonstrated a macrocytic anemia. Given the value of her low vitamin B12, it's likely due to this origin. Folic acid was within normal limits. Basic metabolic panel was within normal limits. Lipase was in normal limits. Urinalysis was unremarkable, negative for any signs of infection. Positive hydrogen breath test, and no diagnostic imaging that had been performed. Assessment and plan then. The assessment is small intestinal bacterial overgrowth. For the treatment for this, it leads into my research question. So I would like to know, can daily administration of probiotics decrease the rate of developing small intestinal bacterial overgrowth, or SIBO, in patients on proton pump inhibitor therapy? Additionally, are probiotics efficacious as an alternative treatment to SIBO infections? So the next section, I'm going to go through some background information. I'm going to walk through each of these sections below. A GERD, or gastroesophageal reflux disease, is the unopposed movement of stomach contents into the mouth or the esophagus. So what happens is right here is the lower esophageal sphincter. Different things such as hormones and food cause this to relax more than it should, where gastric contents can come up and through the stomach, which can cause issues for the patient. It's the most prevalent GI disorder in the United States, affecting 60 to 70 million Americans. An estimated $142 billion per year is spent on the disease. Symptoms can include heartburn, chest pain, acid regurgitation, typically all postprandially. Diagnosis is typically clinically, but definitive diagnosis can be obtained through esophageal pH probe that goes down through the esophagus. A treatment is either first-line therapy is typically lifestyle management with trying to elevate the head, exercise more, and limit certain triggers of food. But we can use histamine type 2 receptor blockers as well as proton pump inhibitors if that does not work. And the treatment of this is imperative because of the complications. So it can lead to esophagitis, Barrett's esophagus, strictures or narrowing of the esophagus, and ulcerations as well. And given the significance of this disease and the burden in the United States, ideal therapy is vital importance. So the vital therapy that we often use is proton pump inhibitors. Proton pump inhibitors, or PPIs, common names are omeprazole or Prilosec, esomeprazole, Nexium, lansoprazole or Prevacid, and pantoprazole or Protonix. The way that this drug works, the stomach has parietal cells, and on the luminal surface of these parietal cells is a hydrogen potassium adenosine triphosphate pump, and the drug, once administered, goes through and irreversibly binds, meaning that there's nothing that can be done to unbound the drug to this receptor, and it blocks the gastric acid secretion. Oftentimes, you'll see therapy for 4 weeks with typical symptoms and 8 weeks for erosive esophagitis, or Barrett's esophagitis can be even longer than that. Large number of patients continue to use this longer than recommended, though. Oftentimes, patients continue to stay on these medications because they're on their medication list and they want to be a good patient and continue to take it without asking further questions on to why they're taking it. Side effects from taking this medication can include kidney disease, infections, osteoporosis, and gastric cancer. However, a recent study has also provided a loose association with SIBO and overgrowth. Which leads me into my next topic of small intestinal bacterial overgrowth. So what is it and how does it develop? It's prevalent in about 0 to 15.6% of healthy individuals. It is defined as a bacterial population in the gut of greater than 10 to the 5th, 10 to the 6th organisms per milliliter. A typical healthy gut biome has about 10 to the 3rd organisms per milliliter, and the majority of those are gram-positive organisms. It can develop secondary to normal homeostatic mechanisms that are controlling the enteric bacterial populations and the gut biome being disrupted. Two common ways that this can happen is through diminished gastric acid secretion as well as small intestinal dysmotility. Diminished gastric acid secretion can occur through decreased growth of ingested bacteria. Oftentimes with medications, it is an H2 blocker or a PPI, as I already talked about. Small intestinal dysmotility can also work by impairing the gastric peristalsis, which causes stasis of the bacteria and food to build up into the upper GI tract, producing overgrowth. Populations at risk for SIBO include those with irritable bowel syndrome, metabolic disorders, aging, celiac disease, pancreatitis, and morbid obesity. How do these patients often present? Symptoms are pretty nonspecific. They'll often complain of abdominal distension, bloating, abdominal pain or discomfort, weakness, and diarrhea. The frequency and severity of The symptoms are correlated to the degree of bacterial overgrowth and extent of mucosal inflammation present. We can also start to see side effects from nutritional consequences of maldigestion and malabsorption of the nutrients in the small bowel intestinal lumen. So these include malabsorption of fat-soluble vitamins such as vitamins A, D, E, and K, as well as carbohydrate malabsorption, and it can also lead to a B12 deficiency. Deficiencies in these vitamins can increase the risks of microcytic and macrocytic anemias, polyneuropathy, and metabolic bone disease. The diagnosis of SIBO is pretty controversial. There's not a gold standard for diagnosing this. Initially, they had thought that the best and most accurate method would be to obtain anaerobic and aerobic colony counts from the small bowel lumen. This could be done through either endoscopy or colonoscopy. However, given the risks and complications of these procedures, as well as sedation, there's few limited diagnostic testing centers that actually perform this. This has led to other forms of indirect testing. One of those ways is through breath testing, which is through quantifying an exhaled gas that's produced by the bacterial metabolism of ingested substrates. These substrates that are commonly used are lactulose, glucose, sucrose, and xylose. There hasn't been a real consensus on a superior substrate or even what values constitute a positive test. Despite this, it is the most commonly used today, even though there is a lot of concerns of validity and high false positivity rates. The treatment of SIBO addresses three main areas. The first is going to be correcting the underlying cause of what is causing the SIBO. For somebody with celiac disease, it's going to be more strict diet adherence. For somebody with diverticulosis, changes in their small bowel anatomy need to be addressed, as well as even medication causes. Then the second step is going to be to provide nutritional support. So if they're lacking those vitamin B12 or fat-soluble vitamins, those need to be corrected, as well as any calcium and magnesium deficiencies. Third is going to be addressing the overgrowth itself, which is oftentimes with an antibiotic. There's also not a true consensus on the best antibiotic treatment for SIBO. Ideal therapy would obviously be based on culture and sensitivity. However, as previously discussed, this is very difficult to obtain due to the complications of the procedure. Traditionally, it was thought that tetracycline would be used. Others would include augmentin or ciprofloxacin. The newest drug that has come out that can be used is rifaximin or rifamycin. This drug, though, is $2,000 plus for one course of therapy, which would be taking one tablet 3 times a day for 14 days. The average treatment of duration of antibiotic use is 7 to 10 days. It's associated with large placebo effects, high cost, potential complications such as C. diff, drug interactions and side effects, and need for recurrent doses. To highlight this, one study shows the average duration of symptom improvement on an antibiotic is 22 days, which isn't even a whole month. So there would be at least 12 courses of antibiotics administered throughout 1 year. Lastly, we're going to cover information about probiotics. The definition of probiotics are live microorganisms which, when administered in adequate amounts, can confer a health benefit to the host. Preparations can include lyophilized tablets and powders, non-lyophilized tablets and powders, fermented beverages, and yogurts. Common strains include Bifidobacterium, Lactobacillus, Saccharomyces boulardii. There's a lot of popularity about probiotics, and it surrounds the belief that intestinal microflora can provide protection against various diseases. Oftentimes, the gut bacteria in the human body is disrupted through the consumption of food processes, antibacterial substances, and high standards of hygiene that disrupt it. Probiotics can work by improving this gut barrier function and receptor interactions to produce and secrete substances such as neurotransmitters and short-chain fatty acids. It is important to note that the FDA does not oversee any regulation of the probiotics or standards for safe consumption, so there's not a lot of published literature on different side effects and complications from probiotics, and the FDA does not necessarily endorse them. So my research question, just to highlight it again, can daily administration of probiotics decrease the rate of developing small intestinal bacterial overgrowth in patients on PPI therapy? Additionally, are probiotics efficacious as an alternative treatment in SIBO infections? I'm going to go over the methods that I used. The way that I developed my research question was through using a population intervention comparison outcome, or PICO model. The type of study that I used was a systematic review of literature where I searched PubMed and Medline full text bibliographic databases. Keywords that I had used included SIBO, or small intestinal bacterial overgrowth, and PPI, or proton pump inhibitor, or esomeprazole or pantoprazole, and probiotic bacteria, or probiotic therapy, or probiotic prophylaxis. I collected all my studies between October of 2021 and June of 2022. I made sure that the studies were screened by title and abstract initially, and then used that to make sure that they fulfilled inclusion and exclusion criteria. After that, I performed a further in-depth analysis and comparison of the results. Citations were then downloaded into a RefWorks citation manager software. Inclusion criteria that I used for my study, I did have to keep it pretty broad because I was unable to find too many results looking specifically at SIBO and probiotics. Inclusion criteria included investigation prevention of SIBO infection through administering probiotics, concomitant treatment of a disease with both PPI and probiotic therapy, focusing on treating SIBO infections with probiotics. Like I said, I did leave it broad, so any study that emphasized probiotic treatment of SIBO were included, as well as herbal therapies and prokinetic therapies. Exclusion, any study that was published before 2000 or after my end date of collection of study, which was June 1st of 2022. If they did not provide full access to the full article, they were excluded. I did not have any exclusion criteria on geographic location of the study, as well as the age of participants in the study. My results: the Medline with full text bibliography database produced 26,217 search results. I reviewed the first 4 pages of these before I felt like relevance was diminishing, and so 3 articles were used. PubMed bibliographical database had 13 results, and I reviewed all of those and found 3 articles. The 2 studies investigated probiotic supplementation in the treatment of the diseases other than SIBO, and 2 studies targeted the pediatric populations. Countries included in my research were Romania, China, Indonesia, Iran, India, and the United States. The publication dates that I included in my study range between 2012 and 2019. Next, I'm going to highlight some of the studies that I categorized for better comparison. The categories are provided below, and we'll go through each one of those. So the first category is the concomitant probiotic therapy with proton pump inhibitors. The study by Sun et al. Was a randomized controlled trial in patients with reflux esophagitis. He had 134 outpatient or gastroenterology inpatient participants with a diagnosis of reflux esophagitis. He divided these into 2 different groups. The first group had 67 participants that were administered esomeprazole and a probiotic 3 times a day for 8 weeks. In the second group, also 67 participants were administered esomeprazole twice a day plus a placebo for 8 weeks. They then performed a 12-week follow-up to review endoscopic and clinical resolution. So a total of 66 patients in the probiotic group completed treatment and 64 patients in the placebo group completed treatment. There was no statistical significance found between the two groups when they compared the healing rate and reflex diagnostic questionnaire. The gastrointestinal symptom rating scale for diarrhea was significantly decreased in the probiotic group compared to the placebo group. There was also negative rate of SIBO in the probiotic group that was statistically significant compared to the placebo group. The relapse rate and risk of relapse was lower in the probiotic group during the 12-week follow-up. That was statistically significant. They concluded that esomeprazole in combination with probiotics had a positive effect on reflux esophagitis. The next category for comparison is administration of probiotics with proton pump inhibitors in children. This study, Hager et al., was a double-blinded, placebo-controlled randomized trial in 70 patients where they evaluated the incidence of SIBO in children that received omeprazole, and they also wanted to see whether probiotics influenced the incidence of SIBO while on omeprazole. The diagnosis of SIBO was confirmed based on suggestive symptoms and positive glucose breath test before the study was performed. 36 patients had received 20 milligrams of omeprazole daily and a probiotic for 4 weeks, and then 34 patients received 20 milligrams of omeprazole daily plus a placebo for 4 weeks. They then performed a second glucose breath test 4 to 10 days after the end of therapy. They found poor medication compliance in 29 patients. 18 of those were with the PPI, and 11 of those were with the probiotic and placebo. After their 4-week therapy, they found that 21 out of the 70 subjects had a positive breath test, and 62% of them felt symptomatic. 5 of the children that had SIBO symptoms had a negative breath test, and 44 children were symptom-free with a negative breath test. So overall, 66 out of 70 participants were either symptom-free or clinically improved. They found no statistical significance in the difference in the incidence of positive breath tests for SIBO between the two groups. They concluded that based on the loose association between PPIs and SIBO, the side effects should be more frequently considered, in that probiotics did not prevent the development of SIBO. Study by Balit et al. Was a 3-year prospective study at an academic referral pediatric center. They had 128 children with the diagnosis of GERD that had been treated with a PPI for 12 weeks, paired against 120 consecutive healthy age and gender matched subjects, which was their control group. So the 128 children were then randomized into 2 different groups, a placebo group of 64 children that received a PPI and placebo for 12 weeks, and then a probiotic group of 64 children that received a PPI and probiotic. The children in the control group did not receive any medications. The diagnosis of SIBO was confirmed through positive glucose hydrogen breath test and the presence of GI symptoms that they evaluated through a Likert scale of symptom severity. They found frequency of SIBO was 0% before treatment in both groups of the children that had GERD, but it was 5% in the control group. After 12 weeks of therapy, SIBO rates were detected in 36 of the 64 children enrolled in the placebo group versus 6 of the 120 children in the control group, and 4 of the 64 children in the probiotic group had tested positive for SIBO. The association of probiotics compared to esomeprazole was significantly decreased the prevalence of SIBO among children with GERD when they compared it to only PPI and placebo. The children treated for GERD and PPI and probiotics had a lower prevalence of SIBO compared to the comparison group as well, but that was not statistically significant. So of the 36 children with GERD that had been treated with PPI and placebo that were positive for SIBO 12 weeks after cessation of treatment, 23 had developed intestinal symptoms. 4 children with GERD from the probiotic group who had tested positive for SIBO were symptom-free after 12 weeks of treatment. So their conclusion was the administration of probiotics decreased the rate of SIBO among children with GERD on PPI therapy and significantly reduced the expression of digestive symptoms in the group testing positive for SIBO. Their recommendations were, because of the anti-secretory therapy that GERD requires with the PPI, there's possible benefit from using a probiotic as well to help reduce the risk of SIBO. And they specifically recommended the strain L. reuteri in children with GERD on PPI therapy. So I broke down some of the figures here that showed pre-treatment and post-treatment hydrogen breath test results among the 3 different groups, as well as their p-values to show statistical significance. And then this chart demonstrates the presence of symptoms in the post-treatment positive hydrogen breath tests. Third category that is going to be compared is the prokinetic effects on SIBO prevalence and those on PPIs. So this was a standalone study in this comparison by Revaya et al. It was a single-centered cross-sectional study that evaluated the prevalence of SIBO in orocecal transient time in those on PPIs compared to PPIs plus prokinetics. So just some context here, the orocecal transient time is the amount of time it takes from food to travel from the mouth to the cecum of the intestine. It's measured using ingestion of lactulose solution until they detect hydrogen peaks at 10 and 20 parts per million while passing the ileocecal valve. And so basically it helps to determine how fast food is being moved through the GI tract. And then prokinetics are a group of drugs that propel food and bacteria through a stagnant colon. So their study was with patients that were older than 12, and they divided them into 2 different groups, those that had taken PPIs alone for more than 3 months, or those that had taken a PPI plus prokinetic for more than 3 months. The PPIs used in the study were pantoprazole, rabeprazole, and omeprazole, and the prokinetic that was used was levosulpiride. So they used lactulose breath test in the orocecal transient time to detect SIBO presence before and after the study. There was a total of 147 participants in the study. The first group was 91 patients with PPI only treatment, and the second group was 56 patients with a PPI plus prokinetic treatment. So they found SIBO was present in 14 patients and normal in 134 patients. The prevalence was lower in the group with the prokinetic agent compared to the PPI only group. The orocecal transient time was delayed in 102 patients. Of those, 68 of those patients were in the PPI only group versus 34 patients in the PPI plus prokinetic group. The mean orocecal transient time was more prolonged in the PPI only group at 130 minutes versus the PPI and prokinetic group at 120 minutes. There was no statistical significance in the difference between symptoms of the groups, as well as no statistically significant difference in the symptoms between SIBO negative and SIBO positive patients. There was no statistical significant association between a particular PPI and SIBO prevalence. The conclusions of the study, so they demonstrated that evidence of the use of PPIs with prokinetics may reduce the risk of SIBO occurrence, possibly because of its mechanism to enhance intestinal motility. There was concern, however, for long-term use of prokinetic agents like levosulpiride, cisapride, domperidone, and metoclopramide. They might have adverse effects such as extrapyramidal symptoms, hyperprolactinemia, and arrhythmias with long-term use. The last study was a comparison in the probiotic efficacy in the treatment of SIBO. So Khalili et al. Performed a randomized double-blinded study among 30 patients with chronic abdominal pain and discomfort or changes with defecation without any anatomical or functional diagnosis other than that of SIBO. So they made sure the diagnosis of SIBO was present through a hydrogen breath test before the study. Each patient received 3 weeks of aggressive antibiotic therapy prior to group placement in the studies. So then they broke up these 30 patients. 15 patients were placed into a probiotic group and prescribed maintenance therapy, including minocycline twice a day for 15 days, followed by Lactol for the last 15 days of the month. And then the second group was of 15 patients that were placed into a control group and received minocycline twice daily for the first 15 days of the month, and then no medications for the second 15 days of the month. And so each month continued that trend. They repeated this for 6 months, followed by a hydrogen breath test and GI symptoms recorded. At the end of their therapy, they noted that pain had resolved in the probiotic group completely, but only 7 out of the 15 had resolved in the control group. The complaints of bloating, belching, and diarrhea were also remarkably less in the probiotic group. There were symptoms of nausea, vomiting, constipation, and loss of appetite that was present in both groups. The post-treatment hydrogen breath test was negative in 93% of the patients in the probiotic group versus 66% in the control group. They concluded that by adding a probiotic such as Lactol to maintenance therapy for SIBO, improved GI symptoms and prevented likely complications. They did recommend research with a larger sample size to confirm the findings and conclusion. Shedid et al. Performed a review of medical records at a tertiary referral gastroenterology practice in the United States between October 2006 and November 2010. They had 104 patients that had met the symptoms suggestive of SIBO, as well as an initial positive lactulose breath test, completion of a prescribed regimen of either rifaximin or herbal therapy, and received a post-treatment lactulose breath test in order for them to meet the inclusion criteria. The subjects with the new diagnosis of SIBO were given 2 open-label treatment choices that were based on their individual preferences. The first choice was 2 200 milligrams of rifaximin tablets 3 times a day, or 2 capsules of a select commercial herbal preparation twice a day. The rifaximin non-responders were followed up with either a prescription of herbal protocol or triple antibiotic regimen of clindamycin, metronidazole, and neomycin for an additional 4 weeks. So of the 104 patients that met the inclusion criteria, 67 had completed rifaximin treatment and 37 had completed herbal treatment. Of the 37 that had completed the herbal treatment, 17 of them had a negative follow-up breath test. 23 of the 67 rifaximin users had a negative follow-up breath test. 14 of those 41 rifaximin users were offered herbal therapy, and 8 of those 14 offered the herbal therapy had a negative lactulose breath test after completion of rescue herbal therapy. I do think it's important to note here that there is a discrepancy between 23 of the rifaximin users out of 67 and 41 of the rifaximin users out of the 67 does not add up to 67. The paper consistently reported the number 41 throughout, and at the abstract at the beginning of the paper it reported 44 for that group, which would have added up to 67, but because it was consistently reported as 41, that was the number that I provided throughout my research. And then 10 of the 41 of the rifaximin non-responders were offered rescue therapy with triple antibiotics, and 6 out of the 10 of those had a negative lactulose breath test after completion of the rescue therapy. So there's a lot of numbers on this slide. I tried to break it down. A little bit better with this table. So you have 104 patients that were in the study. 67 completed the rifaximin first, and then 37 of those completed herbal treatment first. Of those 67, 23 of them had tested negative for SIBO. 41 of them were positive. Out of those 41, 14 of them were offered herbal rescue therapy. of which 8 were negative and 6 were positive. On the first line for the herbal therapies, so 37 of them took herbals, 17 of them were negative versus 20 of them positive. So they found no statistical difference in rescue therapy with herbals and rifaximin non-responders. They thought that herbal therapy may be as effective as antibiotic therapy in the treatment of SIBO. This was based on the lack of statistical difference between the antimicrobial herbs and the rifaximin. The side effect profile of herbals, also compared to the rifaximin, was not statistically different. They concluded that in the setting of SIBO, patients are able to choose between the antibiotic or herbal therapies based on their individual preferences. This is based on their similar response rates and safety profiles. Further, they felt that if a patient refractory to rifaximin chooses to, they can have herbal therapy instead of triple antibiotic therapy. So here's a table that just kind of highlights all of the results between each of the studies, the age of the population that was studied, the amount of participants in the study, and the elements and conclusion of their studies. And then I'll get into more of the discussion element of my research. Again, purpose of my study was to analyze whether daily administration of probiotics decreases the rate of developing SIBO in those on PPI therapy. Further, I wanted to investigate the probiotic efficacy as an alternative treatment of SIBO infections. So I went through and did side-by-side comparisons of some of these studies. The first side-by-side comparison is with the pediatric studies. So Hager et al. And Bali et al. Were both pediatrics. Hager et al. Tracked the correlation between PPI and SIBO prevalence in children, as well as if probiotics influence that incidence. They found no statistically significant difference in SIBO prevalence with probiotic addition. However, they did have poor medication compliance in their study, and their study was a 4-week therapy. Bali et al. Tracked the probiotic influence of SIBO incidence in those on PPI for GERD. They did find statistically significant difference in SIBO rates and digestive symptoms with probiotic addition. They suggested a particular probiotic, L-reuteri, with PPI therapy, and their therapy lasted 12 weeks long. So because this study had a larger number of participants, they had multiple variable groups for comparison, and they tried to pair children across groups according to age and gender, I felt like this study had a little bit more weight by Bali et al. They also had therapy for 12 weeks compared to 4 weeks, which could have some influence on the discrepancy on these results. The next comparison is between probiotic administration with gastrointestinal related disorders. So Sen et al. Studied esophagitis. They monitored SIBO prevalence across 2 groups in symptom improvement of disease being treated with a PPI and those with esophagitis. They found no statistical difference with probiotic and placebo in the healing rate and reflux diagnostic questionnaire, but there was significantly decreased symptoms of diarrhea in the probiotic group. So they recommended that probiotics in addition to standard treatments for esophagitis. Bali et al. Investigated the diagnosis of GERD and symptom improvement in probiotic therapy compared to the placebo. Both found that statistically significant results decrease SIBO rates among probiotic groups compared to the placebo, and both concluded that probiotics have a positive effect on disease management. Again, the standalone study on prokinetic agents. So the prokinetic agents can help alter the gut biome by promoting healthy gut flora through increasing GI motility, and that way it is a little bit similar to probiotics, and so I do think it has some weight on the role that probiotics can play. They also, in this study, found that prokinetic agents do offer some positive benefit in reduction of risk of SIBO occurrence. They thought there should be some consideration in adding this agent to probiotics, given its ability to promote restoration of the gut biome through decreasing the time that harmful bacteria are able to grow in the GI tract. They did recommend caution with the long-term medication side effects of these prokinetics. So my takeaway from this was if there's a lack of evidence right now with probiotic side effects and they work just as efficaciously as prokinetics, then maybe probiotics should be given favor over prokinetics first line. My last comparison was the probiotic efficacy in the treatment of SIBO. So Kaligi et al. Performed a 3-week antibiotic therapy before they broke up their participants into different groups. They found statistically significant improvement in the maintenance therapy of SIBO rates, GI symptoms, and complications with addition of lactol probiotic. They recommended probiotics as maintenance therapy for SIBO. Shadid et al. Compared standard SIBO treatment of antibiotics to alternative herbal therapies like a probiotic. Those testing positive for SIBO after the first round of therapy were given additional antibiotic or probiotic therapy. I think that this was very significant because it provided a direct comparison to those that had failed either the herbal therapy or the antibiotic therapy in tested resolution with the alternative therapy or another round of repeated similar therapy. And they felt that herbal therapy may be as efficacious to antibiotic therapy in the treatment of SIBO, which is important because if the efficacy is the same, then it may make sense to administer not only a cheaper medication such as a probiotic, but one that you can take on a daily basis without worrying about as many side effects. This one was also the only study that was performed in the United States, which I think has significant influence because the differences in our genetics as well as our lifestyle and dietary intakes can differ across different countries. My overall discussion: differences in research design, population ages, geography, and research questions can make a difficult conclusion for my research. Some studies were able to find statistical significance of positive benefit on SIBO in the probiotic administration during PPI therapy. Other studies found no statistical difference in the resolution of SIBO on probiotics compared to antibiotics. There was inconclusive evidence to suggest whether probiotics can be used for alternative monotherapy in the treatment of SIBO, but there is possible benefit in adding probiotics to maintenance therapy. Probiotics also can have some aid in symptom control in those with gastrointestinal disease. The absence of statistical significance between probiotics and antibiotic administration may suggest mild to moderate benefit from probiotics, especially in those unable to tolerate current standard antibiotic therapy. Limitations of my study: there was few research studies that were available for comparison. There was a small sample size in my studies, and there were differences in the geographic locations of the studies. There was also differences across the different methodologies and research designs in the studies, and this systematic review of literature was only conducted by one researcher, myself. I also think that some value should be put on the difference in the probiotic strains that were administered, the type of administration, and the duration of the administration of the probiotic. So my current recommendations on next steps: information about SIBO treatment is underreported and understudied, so that should be given some emphasis. Redesigning promising studies in this systematic review with larger population sizes is always a better way to validate results. Assess restoration of normal gut flora and SIBO clearance rates with a combination of probiotic and prokinetic agents. See if they compare to one another. Conduct studies across longer duration and treatment intervals. As like I said, some of the studies were only 4 weeks long. I would be interested in repeating those studies over long duration. And assessing the impact of long-term PPI use on SIBO rates and preventive measures, since these studies Most of the patients were only on a PPI for a few months. My conclusions: this study evaluated the prevalence of SIBO infections among those on PPI monotherapy to those on PPI plus probiotic therapy. It also aimed to assess treatment of SIBO in standard medical care to herbal medical alternatives. Probiotics did seem to improve symptoms related to SIBO and other GI disorders, although it remains unclear what impact they have at reducing SIBO rates. The same can be held true for probiotic treatment of SIBO infection and with additional traditional antibiotic therapy. Thank you for listening to my research presentation. If you have any questions, my email is provided below. The following slides are my references. Thank you.